I'll go ahead and give a brief update on developments in upper tract cancer. These are my disclosures, and I'll just mention the relevant disclosures in the few minutes that I have. So I just want to first talk about the POUT trial. So this was a phase 3 trial done in patients with high-risk upper tract disease following nephroureterectomy. Patients had invasive cancers. They could have positive nodes or negative nodes, but no distant metastatic disease, predominant urothelial, and fit to receive chemotherapy within 90 days. This was done in the UK. Alison Bertle was the PI. This is a description of the patient population, 260 patients randomized to the two arms. You can see the pathologic tumor stages. The majority of those patients had advanced disease. Not as many patients with positive nodes. And you can see the typical distribution of patients who would be platinum eligible and non-platinum eligible and the distribution of location. This is the Kaplan-Meier plots with the confidence limits in both disease-free survival and metastasis-free survival, showing a benefit in the adjuvant therapy, and the forest plot looking at the planned subset analysis. And the benefit was accrued to both. There was an overall benefit. Some people have teased out the perceived lack of benefit in patients who were not platinum eligible. You can see that in the gem carbo arm, but I think suffice it to say that this provides fairly high level evidence in support of adjuvant therapy for patients who don't get neoadjuvant therapy but have high risk disease. So in the neoadjuvant space, we have a small phase 2 trial that's been reported. This was ECOG 8141. Vitaly Margulis, urologic oncologist at UT Southwestern, was the PI, and Jeannie Hoffman-Sensis from Hopkins, medical oncologist. And this was the trial design. It took two groups of patients, platinum eligible, platinum ineligible. The ineligible arm accrued very, very slowly. And I think this was because, or perceived in part, that the medical oncologists weren't wild about giving carboplatin-based therapy. But in the platinum eligible arm, they got accelerated or dose-dense MVAC for 4 cycles and then went on to get a nephrectomy or nephroureterectomy and a regional node dissection. Small study, and they had about a 10% path CR rate. This is very similar to what the MD Anderson group reported in a retrospective cohort study. I think their path CR was 15%. And this is the Kaplan-Meier plot from that study. There is a clinical trial, follow-on clinical trial that's likely going to combine chemo and IO that's been approved by CTEP, and I'm told that ECOG is putting the final touches on the protocol, and hopefully that'll be available within the cooperative group system in the near future. Since we have Sia leading us today, I just want to acknowledge him and Monty Paul is leading this important trial from QED. I do have a consulting relationship with them, and I serve on the steering committee for this trial, though not as a volunteer. So this is an adjuvant trial, again, for high-risk patients using their drug infigratinib, which is an oral FGFR 1 through 3 selective kinase inhibitor. We heard earlier today about the approval of a different FGFR inhibitor in the patients with metastatic urothelial cancer who'd failed platinum therapy and often failed IO therapy. They presented at ASCO this year a small phase 2 trial in advanced disease that met its primary endpoint. This was a heavily pretreated patient population, but both in first line and second line therapy, there appeared to be a reasonable response in overall survival, showing activity of the drug, not surprising. And then this is the trial design of Proof 302, which is ongoing. And it's a randomized trial to the study drug versus placebo in high-risk patients with a primary endpoint of disease-free survival. And again, Sia can enlighten us further on that if time permits. I'll finish by the Olympus study. This was sponsored by Urogen, which I have a longstanding consulting relationship with. And I was also the scientific PI of this study. So this is a prospective study in patients with low-grade disease in the renal pelvis, restricted to proximal to the UPJ. Patients with ureteral tumors had to have these treated prior to registration. This is a thermoreversible gel with mitomycin, which is a viscous liquid which can be injected via retrograde ureteral catheter, and then forms a semi-solid gel which is retained in the upper urinary tract for about 4 to 6 hours. And the benefit there, of course, is the longer exposure of mitomycin C, which the gel is admixed with. So patients had to have biopsy proof and low-grade disease. They got intracavitary treatment once weekly for 6 weeks, and then 6 weeks later had ureteroscopy, cytology, and for-cause biopsy to demonstrate a complete response. And then those that had a complete response could go on to once-monthly installations with Q3 month ureterorhinoscopy. There was a 59%, actually it's been revised to 58% complete response in 41 patients, which blew away the low threshold of 15% set by the FDA. And this was the same in patients who had unresectable or resectable disease. About half the patients had disease that for a variety of reasons could not be completely ablated. We did leave a 5 to 15 millimeter so-called marker lesion in place. So this was testing a chemoablation strategy. These are the adverse events. A lot of attention has been paid to ureteric stenosis. The vast majority of these patients could be managed with stenting. There were a few nephrectomies and at least one related to, or two related to this issue of ureteral strictures. But this got FDA approval in April and is ready for use in patients with biopsy-proven low-grade disease. So just in summary, the POUT is a new standard of care for adjuvant chemotherapy in high-risk disease. The cooperative groups are looking at a new neoadjuvant trial, and then the oral FGFR3 inhibitor trial is ongoing in adjuvant high risk. So thanks so much.